Thanks very much, Duncan, for that introduction, and thanks again to the TVN board for the opportunity to come and speak to you a little bit about frailty and critical illness, and a little bit about an implementation project that has been funded through TVN. So I thought I would first perhaps describe to you a little bit about the epidemiology of frailty and critical illness, and use a sort of pilot multi-center study that we have done in Alberta to give you some data on that. Then I'll provide a brief overview of the Frailty Bedside Clinical Information Implementation Project, and then I'll be happy to engage with you and solicit any feedback that you may have. So we did this multi-center prospective observational cohort study in Alberta a few years ago, and I can say honestly that myself and Rob McDermott, one of the co-investigators, literally were at the bedside one day of a critically ill patient who was a bit older, and we said to ourselves, he looks frail. But it dawned on us that we really didn't have a good understanding of how to operationalize that, nor did we really have a good understanding of what the implications of a patient who was frail, who developed critical illness was, in terms of their short or long-term prognosis or outcomes per se. So literally what turned into what was inspired to be a small pilot study to investigate this was expanded in scope to be more provincial in nature. And so we had six centers, 2 academic, 4 community hospitals to get a nice representation of the province, and all adult patients over the age of 50 admitted to the ICU and expected to survive for at least 24 hours were enrolled. They were screened after they came into the ICU for eligibility. We reviewed their medical records. We interviewed the patients if applicable, if not their surrogate decision makers. We assessed their exposure, which was frailty, and we used the clinical frailty scale, which you've heard about already many times today, based on their pre-hospital disposition. And our outcomes of interest really were, hospital mortality, but also we wanted to know about adverse events, rehospitalization, and we followed them out for 12 months to look at their health-related quality of life at 6 and 12 months. So this is the clinical frailty scale. Again, we've seen it already today, and we use this to ascertain the exposure for our patients. So we had it administered by trained coordinators and also by the bedside clinicians most responsible for the patient's care, also filled it out as well. We screened nearly, or just over 2,000 patients, and ultimately we had 421 patients who fulfilled eligibility, were enrolled, and we had vital status ascertainment at 12 months for. So just to give you some idea about the prevalence of frailty that we saw in the ICU in Alberta, about 1/3 of patients were classified as frail, and this would be a clinical frailty scale score of greater than 4, 5 or greater if you like. So that was quite surprising to us that it was such a high prevalence. But what we also found too, which was interesting, is a full additional 1/3 were actually deemed vulnerable. So they scored 4 on the clinical frailty scale. So you could make the argument that 2/3 of the patients who were admitted to ICUs in Alberta, perhaps, at least within the confines of the trial eligibility criteria, were in fact vulnerable or frail. So what about some of the baseline characteristics? And it's interesting, you can see that the age, there's 2 columns here, frail and non-frail. You can see that the age of these patients is not as old as you might think. We've heard earlier about frailty being highly correlated with aging and certainly being more prevalent amongst older persons. But what's interesting to me is that to be susceptible to critical illness to the point where you need to come into an ICU, I think, in fact, frailty may be age shift to some extent, and that was one of our hypotheses. So you can see they're a little bit younger, albeit those that were frail were a little bit older. Many of the other clinical features here are consistent with what we may understand about a phenotype of frailty, if you like. Certainly these patients had more comorbid illnesses, were prescribed more drugs, were more likely widowed, had less likely gone on to postgraduate education, even high school education for that matter. When we look at some of their baseline characteristics, it was interesting as well. Far fewer frail patients were independent at home, and clearly they had a lot of deficits in their activities of daily living on full assessment. Not only that, patients who were frail were more likely to have been hospitalized in the preceding 1 year than those that were not frail. What was interesting to us as well is that once patients got into the ICU, and it's probably important to clarify this, is that Patients were assessed after admission to ICU, so there was no triage decision made around this study. So all assessments are based or anchored within the ICU itself. So there is a bit of a selection bias here. Certainly some frail patients may have been seen and not admitted to the intensive care unit. We would never have seen them to enroll in this study. But the point of this is that if you look at the intensity of support of these patients, once they were in the ICU, they received an intensity of support commensurate with their illness severity. So they got the same likelihood of being mechanically ventilated, receiving vasoactive support, renal support, etc., that patients who are not frail did. So basically, they were treated the same once they were there. But their outcomes were a little bit different. Frail patients were more likely to suffer adverse events. Frail patients were more likely to stay longer in ICU. But their ICU mortality, in fact, was identical. And that's interesting to us. There was no difference in their mortality in the ICU. However, once they were discharged from ICU, we found that their mortality in hospital was almost twofold higher than patients who were not frail. The frail patients stayed longer in the ICU, as I said. They also stayed longer in hospital. And this might be very fitting with our understanding that frail patients might require a lot longer period of time to recover from an acute insult like critical illness, whatever it may have been. Importantly, some of the other outcomes we saw is that patients who were previously home were less likely to be, frail patients who were previously at home were less likely to be discharged home, more likely to acquire new disabilities, more likely to be readmitted to hospital in the subsequent 12 months. And here you can see survival over the year after enrollment in the study stratified by their clinical frailty scale score. So clearly those that had a higher score were more likely to die in the subsequent 12 months. But we did look at their quality of life as well, as I mentioned. And here you can see we looked at 2 validated instruments to measure their quality of life at 6 and 12 months. We looked at their Euroqual EQ5D and at the SF12. And here you can just see the EQ visual analog scale at 6 and 12 months. The green bars represent patients who are frail, and this is their self-described quality of life at 6 and 12 months. Red represents critically ill survivors who were not frail, and I think you can clearly see a difference. The frail patients had a lower quality of life or more impaired quality of life. Both cohorts, in fact, had a much lower quality of life compared with population norms in Alberta. And here you can see as well is that you look at the health-related quality of life relative to the severity of frailty based on the clinical frailty scale. I think you can appreciate as you get to a clinical frailty scale score of 6 to 8 that the quality of life of these patients at 6 and 12 months is considerably more impaired than if the score was lower. Finally, if you look at the EQ5 domains, so the problems that patients may have expressed in follow-up across mobility, self-care, usual activities, pain and discomfort, anxiety and depression, the red and the yellow bars represent frail patients at 6 and 12 months. And I think it's easy to see here that frail patients had much greater problems across all of these domains than patients who were not frail. Albeit, even the patients who were not frail seem to have a high prevalence of these problems. One thing I wanted to comment on quickly as well is that we enrolled patients in the study that were aged 50 years of older. So some of the people in the room here, 50, 55, 60, are shifting in their chair a bit. But the rationale for that was, again, we thought that critical illness and frailty interact such that it might be age shifted, such that we are seeing younger patients in the ICU who may be classified as frail. And indeed, in the age cohort of 50 to 64, about 1 in 4 patients were classified as being frail. We have some more data coming out on that before long. So what were some of the implications of this data this study that we performed? Well, I'll just go through a couple things before I talk about the implementation project. The first was, the implications may be that we can use these kinds of data to better inform triage decisions about the suitability of ICU support for patients. Perhaps we can use these data to better inform ICU-specific decision-making regarding the scope of care, the scope of support, regarding the overarching goals of care, and in the context of survivorship expectations. And I think this is actually very important, that we're able to carefully manage the expectations of what patients, in particular families, can expect amongst a frail survivor of critical illness in terms of their quality of life, their acquisition of new disabilities, their need for health services downstream. In addition, I think it's very important that we could use these data to help inform about transitions of care. And certainly one of my colleagues, Tom Stelfox, has a project that's focused on ICU discharge transitions of care. But clearly, frail patients may have unique features that differ from not frail patients that we could prioritize or specialize in the transfer from ICU to the ward, or in fact, out of hospital. Finally, recognizing that frail patients, that the use of frailty as a measure in critical illness might identify a vulnerable cohort, perhaps we can design interventions that might be able to target these. So we may be able to focus on things that maximize their physical recovery. Some disabilities will never actually reverse, but some may be manageable and some may actually improve over time. Focus on the cognitive and psychosocial and emotional recovery of critically ill patients. And this gets at the idea of the post-ICU syndrome that we're starting to learn about. Frail patients, in fact, may suffer more post-ICU syndrome than not frail patients. Finally, focus on caregiver burden and their experience as well, which would be essential in the sort of seamless recovery of a frail patient from ICU. So this is great. And one of the things that I've sort of thought about in my head over the last few years as we've done this work is we talk about frailty as being a state or syndrome that's often a geriatric syndrome, if you like. And these are some of the interventions that have been sort of evaluated in the literature to address frailty in a geriatric population, if you like. But I think we can translate this into what we do in the ICU in a more acute or immediate sense. ICU-specific equivalents of a lot of these different sort of domains of interventions that might be able to improve the process of care and outcome for patients who are frail in our ICUs. Some of these have been tested, some of these have not. So I think that gives some context to the fact that I think we do see a lot of frail patients in the ICU. And it really gets at the point, if this is a vulnerable cohort of patients, how best can we identify them so that we could enable some of these processes of care or evaluation of interventions to improve their outcome? And so, thanks to TechValueNet, we've put in a grant for an implementation project for a sort of multi-phase pilot project to evaluate the feasibility of implementing the clinical frailty scale as part of the routine admission documentation into an EMR in all ICUs in Alberta. I should qualify that we use the clinical frailty scale in part because of its subjective informity and also its relative simplicity at the bedside of a critically ill patient. It's challenging for us to do a lot of cognitive assessment in the short term for many of these patients. It's certainly challenging for us to do things like a get up and go test or a gait speed or grip strength and things like this that are functional. So this seemed to be the best compromise between using all available clinical information in a relatively short time to come up with a score. So just to give you some background, in ICUs in Alberta, we are in the process of implementing a provincial EMR called eCritical. And really, this is a common clinical information platform deployed to all pediatric, adult, and cardiac surgical cardiology or CCUs in Alberta. It's a bedside system, provides full electronic interdisciplinary clinical documentation and collation of demographic, diagnostic, case mix data, lab data, and device data. So all devices connected to a patient stream direct into the EMR. Ventilator data, smart pump data, renal replacement therapy data, etc. In the back end of that, we have Tracer, the Tracer database, which is a data warehouse and clinical analytics system. It provides comprehensive, multimodal, and integrated data repository of all patient-specific clinical information. So it enables data extracts for administrative or quality improvement or education or research work within the province of Alberta. So this would be, for example, the MD admission form. In eCritical, anytime a critically ill patient is admitted to the ICU, the most responsible physician has to enter admission data on that patient. So what we're proposing, and this is an example of some of the fields that we fill out, demographic data, case mix data for diagnostic purposes, illness severity score data, and comorbidity data, et cetera. But what we would be proposing is that we would add the CFS to the admission forms for the MDs. And then we would enable on their daily sort of assessment, we would enable the CFS score to be displayed. So it could be displayed in the MD homepage. But importantly as well, we would like to be able to display the clinical frailty scale score and or even some clinical support beside it in the nursing charting, but also in all the allied health charting. So you can see here there are domains within this system to chart for pharmacy, nutrition, speech-language pathology, physiotherapy, occupational therapy, and social work. So we would like that would be something that we could enable such that in the end, when the patient is discharged from the ICU, some of this information related specifically to frailty could be exported in the form of a report. So the phases of our work really is about, first is stakeholder engagement, and that's what we've been doing since we heard we were successful in the grant. Education, some focus groups, and a survey about how providers would like to see the CSF displayed in eCritical. Next phase is to custom configure eCritical, so put the CFS into admission forms and display it across providers and get some feedback about that as well. We would pilot implement it in a few selected units that are more familiar with the CFS, and then we would evaluate it. So get interprofessional feedback, audit for reliability and validity. And we think, or at least I hypothesize that it may be value added, that providing a validated measure to systematically identify vulnerable and frail patients to all Alberta ICUs would enable us to identify these patients, right? Perhaps this would provide a mechanism to translate frailty-specific information between providers, so from ICU to the ward, or interprofessional amongst physicians to PT to pharmacy, etc. Also providing a mechanism to design, evaluate, and implement further interventions that may be targeting this vulnerable cohort. A methodology on how to scale this, perhaps completely across the province or to other jurisdictions that have similar infrastructure-supported EMRs in their ICUs. And finally, a platform to potentially develop quality indicators or reduce practice variation or inform policy around this vulnerable cohort, frail patients in our ICU. And so the next steps, beyond this immediate implementation might be that we develop a risk identification tool, that we develop more layered clinical decision support, that we develop more targeted mechanisms for dissemination of information about a patient being frailty, and inform policy and practice. And I won't go into that in any more detail. So with that, I'd conclude by saying frailty can be measured in critically ill patients. I think that's important. I think we've shown some work that proves that. And even in critical illness, it is associated with less favorable outcomes. So if we were to systematically implement a frailty measure, we'd be able to better identify this vulnerable population, and it may have a number of implications for providers and for patients and families as we move forward. I wonder about frailty as a therapeutic target, and I just put it up there as it's less well defined, in particular in the critical care sphere, but it's something that I foresee downstream that we'll look at. And I think our proposal would be first to systematically measure it and make sure that we're measuring the right thing before we move on to all those other lofty goals. So this is far side for the old age truck, but I like to call it the frailty truck. And yeah, I'd like to thank all my collaborators and everyone who's been involved with our program so far. So thank you.